Hello there. This is Aaron Filler. I'm a neurosurgeon in Santa Monica, California, associated with the Neurography Institute and also Cedars-Sinai Medical Center. The principal authors of this chapter are Martin Malaysi of the Leiden University Medical Center in the Netherlands and Alan Belsberg of Johns Hopkins University. This chapter is part of our coverage in the textbook of brachial plexus injuries, focusing on the early management. There are two general clinical categories to keep in mind because the management and the outcomes are quite different. One will be the traction or crush injuries that occur in adults, often in motor vehicle accidents or in a wide variety of other traumatic events. And then the special case of traction lesions of infants from complicated delivery. And these are an important distinction because the patients often have a much better outcome given their very young age and the greater ability of the nervous system to undergo its own repair and regrowth. Most brachial plexus injuries involve some forceful widening of the shoulder-neck angle, and we'll go through this in the slides following. And overall, the severity of the injury is determined by the magnitude of the kinetic energy applied. We'll do a quick review of the brachial plexus, which, as you know, is a complex set of nerve elements involving spinal nerve roots from C5 to T1. We'll also review the detailed structure of nerves, which are the axons surrounded by Schwann cells and a lamina tube, basal lamina around the Schwann cells, and then a series of other layers, all of which have various degrees of resistance to trauma. But certainly at the level of the lamina tube, all elements really need to have continuity and viability to conduct action potential and action potential. Two classes of injury worthwhile of distinguishing. First would be those where the basal lamina is intact, and there, even if the axon is disrupted, there's a fairly good chance of regrowth and restoration of function. On the other hand, there's the class of injury where the basal lamina is severed or disrupted, and depending on the extent of this in any given nerve, recovery would only be possible with surgical repair. As noted above, the repair goals may be more ambitious for infants because of the greater potential for recovery. And the two major classes of repair plan include stump resection and coaptation, or bridging of gaps with grafts or synthetic tubes. All of these where there is intact function proximally, and a very different set of challenges where there's a root avulsion from the spinal cord, so no potential to simply bridge a gap to obtain recovery. And there the strategies are primarily concerned with nerve transfers, which bring innervation from another segment, another source, to then travel out through the peripheral nerve to obtain function. Now, a little more detail about these two clinical categories, the first being the situation of shoulder dystocia in a complicated delivery. And as demonstrated here, the issue is a downgoing shoulder or upgoing shoulder entrapped in the birth canal, where the obstetricians maneuvers, if there's a difficulty with delivery, may potentially complicate the delivery. A lot of attention is directed at detecting this type of situation in advance or early on, and decision making to either use manual methods to try to avert a nerve injury or surgical supplementation to help access and optimize the delivery to avoid the nerve injury. Nonetheless, shoulder dystocia, brachial plexus injuries continue to occur, and neurosurgeons are often faced with the problem of how to fully diagnose these and how to plan treatment, what the options are, and what the timing should be. A typical type of injury causing a brachial plexus rupture or various classes of damage would be the one depicted here. Motorcycle accident, where you can see this driver's injury involves his shoulder being pushed downwards as his head is pushed in the opposite direction. The blow up of the image demonstrates several degrees of severity of injury that may occur, showing root avulsions at C5 and C6 and C7, which are essentially not possible to repair, whereas at C8 we're showing a physical separation rupture, and at T1 an internal injury, but the external continuity is preserved. Now, it's important to keep in mind that at C5, C6, and usually C7, there is a significant fibrous attachment of the root sleeve to the transverse process, so that the type of abnormality shown here, where you have the root avulsions at C5, 6, 7, is usually opposite in the sense that the adhesion of the epineurium to the transverse process tends to protect against avulsion at C5, 6, 7, whereas that C8 and T1 that don't have that fibrous structure are more likely to get the root avulsion. So this really just demonstrates the types of injuries. Now, it's worthwhile to do a review of the anatomy of the brachial plexus. I have here both a diagrammatic representation and a more anatomical drawing. First, we have the roots, C5, C6, C7, C8, and T1, which transition into spinal nerves, and the root essentially is upstream of the conversion from dura to epineurium, and then there's spinal nerves from that point. We have a few proximal nerves coming off along thoracic, phrenic, not shown here, dorsal scapular. The upper, middle, and lower trunks of the brachial plexus, these dividing into the anterior and posterior divisions. And then we have a lateral cord, which has the descending component of the muscocutaneous to the biceps, and part of the contribution to the median nerve coming from the upper spinal segments. And then we have the posterior cord with the innervation to the thoracodorsal and subscapularis musculature. And then we have the posterior cord further dividing with the axillary nerve coming out to the deltoid, and the radial nerve innervating the various arm, elbow, and wrist and finger extensors. Then the medial cord with the median nerve contribution from the lower spinal segments, and also the ulnar nerve. It's this pattern that gives this quality that an injury to the lower trunk affects the motor to the hand in the sense of both median and ulnar contributions, which are separated distally once the ulnar and the low motor contribution to the median have separated. I note the abbreviations, definitions there, the subscapular nerves, thoracodorsal, and the medial brachial cutaneous and medial antebrachial cutaneous is noted. And then just looking at the anatomical representation, there's another view of how you categorize this, the very proximal portion of the plexus with the roots, and the preganglionic, and then the ganglions for the sensory side, the upper, middle, and lower trunks, which you see once they're formed, they're in a position to cross over the first rib, and then we have the potential for compression between clavicle and first rib at the level of the divisions, and then more distally the cords and final branches and nerves. So it's also worthwhile to review the internal anatomy of nerves and understanding injuries and repair requirements. We have at the most outer level the epineurium, which is a strong fibrous element which may be able to maintain continuity when everything inside is fully disrupted. So this is why you may seem to have an intact nerve, because the epineurium has remained intact when internally there's very severe disruption. The next level of organization within the epineurium is the interfascicular epineurium, which is a fatty material that separates the fascicles. And then within the fascicle groups, we have the actual fascicles themselves. A fascicle has a surrounding of perineurium, and the perineurium defines a privileged space within, which is a low protein fluid which forms a blood nerve barrier in the perineurial layer, and the endoneurial fluid has a bulk proximal to distal flow. Within the space of the fascicle, we then have the individual nerve elements. Each nerve element is surrounded by a basal lamina, and then within the basal lamina we have the myelin sheath, and then finally the axon. And so with all this in mind, we can consider more about what has to be done to restore function and how function gets to be disrupted. But you really need to have continuity and viability of everything here to get an action potential. But if only the Schwann cells are disrupted from pressure, you'll get a break, an interference with transmission. Then as soon as the Schwann cells grow back, the axon will again commence a transmission. And also to the degree to which the overall skeletal structure of the nerve is maintained, even if an axon is disrupted, it would be highly likely to be able to follow its correct path back to a distal target. And also the structure of the nerve will inhibit scar tissue formation that might otherwise block the nerves, and also your risk of neuroma formation is low. But as soon as there's a disruption of the basal lamina, you begin to have the situation where a neuroma can form, so that even if the overall continuity is maintained, it may be impossible to restore function without cutting out a neuroma and allowing a new pathway to form. And when the injury is partial, it becomes a trade-off between what natural recovery will be obtained and what is going to be your decision point for proceeding with a surgery, when you don't know ultimately what the natural recovery without intervention would have been. So it's fair enough to summarize these two classes that if the basal lamina is intact, a severed axon can recover without surgery. But when the basal lamina gets severed, depending on the scale of the damage to basal lamina in terms of the fraction of the number of interrupted axons in a given nerve and the size of the nerve and how proximal it is, you have a situation where it may be that recovery can only occur with surgical repair, although your decision making is still challenging because it is difficult to know inside the nerve how severe the damage will be. And traditionally, we would wait 3 and 4 and 5 and 6 months to see if spontaneous recovery occurred, and even at surgery, looking at a neuroma, use intraoperative stimulation and monitoring where electrodes are placed just upstream and downstream of the area of a neuroma formation to see what potential strength is required to drive a signal across the lesion and to understand the degree to which there are fibers intact within, even if the regrowing fibers have not yet reached their distal target. However, more recently, we've come to understand that the likelihood of success is much better in an early surgery because by the time 6 months has arrived, although the nerve will now have declared itself in terms of likelihood of recovery, presence of a Tinel sign showing recovery or progression, nonetheless, what has happened by this point is that the neurotrophic factors that are produced by the distal severed portion of a nerve begin to drop off. That is, shortly after injury, in a severed nerve, the distal portion of the nerve will start to generate a very large output of nerve growth factors. But by the time you've waited 6 months to find out if you should do your repair, the nerve growth factors are dropping off, so that although you're able to now create a situation that allows regrowing axons to safely bridge the gap, the lack of the nerve growth factors distally tends to lead to poor outcome. And this is increasingly leading to an understanding that a decision has to be made early, within the first month or two at most. And if surgery might be needed, it may be pointless to wait, because by the time the potential for regrowth has declared itself, the distal portion of the severed nerve may become increasingly incapable of sustaining adequate regrowth. Now, along with the various classical methods for trying to understand the severity of the injury, we also have advanced MRI techniques such as MR neurography and diffusion tensor imaging, which can help quite a bit. This is an obstetrical injury which demonstrates a number of different types of pathology. In frame A, we can see the C6 spinal nerve with a terminal neuroma. We can see at C5, it's a neuroma in continuity. In B, we can see what looks like potentially a pseudomeningocele. In C, we can see what proves to be a proximal neuroma, and in which is really a swelling at a point of injury. We can see in H, when we focus on very proximal portions of the nerves, the likely continuity of each of the elements proximally. And then in J, just a routine axial T1 image showing that the spinal cord is displaced, and this also can give a clue of the likelihood of an avulsion ultimately, it is still the case, despite looking at meningoceles from myelograms, classic or MR myelography, despite this type of appearance, it is often impossible to be certain of whether or not there is an avulsion without direct inspection, and that's ultimately the gold standard. So in terms of repair, classically, we had the option of trying to pull together severed segments, and the teaching has been that we have to wait for the neuroma to form fully into that 4 to 6 month range, because it's going to be necessary to cut out the neuroma in order to open the path for regrowing nerves to grow across. And if we go in too soon, or we don't resect back far enough, there may be disrupted nerve that is likely to progress into a neuroma that blocks growth, so that we do a very nice repair, but there's upstream neuroma formation after the repair that blocks regrowth. So there's that teaching to allow time for the neuroma to mature. But given the newer information that by waiting for this very clear surgical situation, we've now foreclosed success because the distal nerve is not producing sufficient neurotrophic factors. Subsequently, we may be forced to make the assumption, and during surgery you do serial sections of the nerve with histology intra-op, a frozen section, in order to see when you're likely upstream or downstream of the disrupted area. Also, in addition to using donor interposition grafts from, for instance, the sural nerve in the leg, there is progressive steady advance in technology. So firstly, we have the potential for sleeves, which have proven very effective for gaps in the range of 2 to 3 centimeters and sometimes longer. And so there are many efforts afoot to improve the effectiveness of these synthetic sleeves by, for instance, providing guides to help the nerves efficiently cross, by providing additional growth factors, either from by supplying them from a matrix, or by placing cells that can produce growth factors. So a lot is happening here with different types of surfaces to use, using more complex intubulation to promote growth. And this has had a very big impact on the success of repair, and with increasing lengths of gaps being susceptible to repair in this fashion. It also means that there's only one transition the nerve has to make, the regrowing nerve, so it has to exit a cut and then enter the distal portion, whereas with an interposition graft, it has to exit a cut, enter the interposition graft, then exit the interposition graft, and then make that second entry into the distal cut nerve. And the balance of efficiencies really is in favor of these intubulation repairs in many situations. Now, further, in relation to strategies for repair, the two major classes of options are the use of interposition grafts, as we've been discussing, when there's damage in the nerve, the brachial plexus. However, when there's an avulsion, there is no upstream source, and that is where nerve transfers come into play. And there is an ever-increasing catalog of different types of transfers that can be used, where you have a distal portion of a nerve which can feasibly be sacrificed to innervate a different function. And what's done here is to take a perfectly good peripheral nerve and cut it, and then lead the nerve into the side of a distal portion of an injured nerve, and either the donor is fully cut and allowed to enter it, or partially cut to borrow a portion of the nerves. And this can be done in the chest using intercostal nerves to innervate arm nerves, and it can be used with a number of donor sources, such as the accessory or phrenic nerve even, though you always have to look, of course, at the negative impact of whatever is being borrowed from or retasked. Yet another area of advance is actually reaching across the body to the other side, where we take a root and then lead it across, and this of course takes quite a bit of practice for the individual to learn to operate one side of the body, the arm on the right, for instance, here using nerves that really go to the left. But this is another important component to have in mind. And what is often the objective is to restore certain joints, such as elbow flexion being a high priority because of the very important utility for a person, and then other proximal improvements such as the some sort of shoulder abduction and being able to bring the shoulder inward so that the person can bring their hand up towards their mouth. And then there are a wide variety of secondary procedures which are covered in a different chapter, which can allow for using other muscles, transfer muscles and or fusions of joints to help improve the utility of limited functions. And then the other relevant advance to keep in mind as you consider your patient is the availability of new neuroprosthetics, neuroelectronic prosthetics, also discussed in this textbook, which can allow for distal nerves to be implanted into muscle without trying to restore their whole progress distally, and then having EMG type pickups detect the activity in the muscle and use this to drive through microelectronics a distal prosthesis, either a replacement after amputation or a glove mechanism, so that we can provide function and animation through a mix of surgical and advanced microprocessor-driven electronic technology as well. Thanks very much.